Hello, my name is Dr. Stephen Hodi, and I'm going to be speaking to you today about combinatorial approaches to immunotherapy and using melanoma as an example. So as a clinical investigator, I look at the treatment and development of immune therapies in several ways. So it's really the features of human cancer and how this evolves into immunotherapy interventions. So as opposed to preclinical animal models, tumors in humans are present for a long period of time, and therefore there's a long tumor-host relationship. Metastases likely develop in relationship to some form of immune recognition in patients. And so why do patients who develop metastatic disease do so despite this immune surveillance aspect? Well, either innate immune tumor responses in patients never developed. There could be problems with the antigen-presenting machinery, such as MHC class 1 loss. T cells can be eliminated. They can be insufficient or exhausted. Or the immune effector cells themselves can be excluded from the tumor microenvironment and not gaining access to the tumor from the vasculature. So in the beginning, the first target for immune therapy from immune checkpoint blockade was cytotoxic T-Lymphocyte antigen 4, or CTLA-4. And the basic principle here in this cartoon is that the professional antigen cell, which can be an dendritic cell or B cell, its job is to chop up a protein into peptides and present it on the surface of the MHC as depicted by this red diamond-shaped figure here. And it presents it via the MHC to the T cell receptor to educate a naive T cell to make a specific immune response against that peptide. In order for that to occur, you have to have co-stimulation. And the EPC side is B7, on the T cell side it's CD28. These come together to allow the T cell to gain its ability to do its seek and destroy mission on an antigen-specific level. It allows the T cells to replicate and make important signaling cytokines such as interleukin-2. Now, if this were to go untethered, the T cells would go and start reacting to normal tissues and you would get autoimmunity. And actually the knockout mouse, the CTLA-4 knockout mouse, has demonstrated in a phenotype of an overwhelming lymphoproliferative disease. The mice die at a very young age from this overwhelming lymphoproliferative disease. So it shows the importance of CTLA-4 as a checkpoint. So in this regulatory capacity, the CTLA-4 comes out on the surface of the T cell, has a higher binding affinity to B7 and kind of puts us to sleep, thereby making memory cells and other aspects. So as first proof of human principle here, we use fully human monoclonal antibodies to block CTLA-4 to allow this preferential T cell potentiation, to allow these T cells to go with their seek and destroy mission to kill cancer cells. So this was a study that led to the approval for anti-CTLA-4, or Ipilimumab, or Ipi for short. This was a study done in patients with metastatic melanoma. They could have been previously treated. They had to be previously treated. They had to be HLA-A2 positive because the control arm here is a GP100 peptide vaccine. And they could have had previously treated central nervous system disease. So historically, these are the bad players, second-line patients or more, and potentially patients with brain metastases. In the 3-to-1-1 fashion, patients were randomized to Ipilimumab, or Ipi, anti-CTLA-4, plus the peptide vaccine, versus Ipi alone versus the peptide vaccine alone in a blinded fashion. After 4 cycles of therapy, patients were followed, and any patients who had stable responding disease continued to be followed, and upon any signs of progression further on, were again retreated with the regimen that they were previously randomized to. What this Kaplan-Meier analysis demonstrates that patients who received the 2 Ipi-containing arms, these 2 top graphs, had an overall improvement in survival compared to the peptide vaccine alone. Some important points here is that patients had a kind of a tail of the curve phenomenon, so minority of the patients receiving majority of the benefit, and that the immune system seems to have memory, and that despite many patients only getting 4 doses or stopping or intermittent dosing, that they still have the ability to adapt to changes to the cancer and have a long-term benefit. Again, here depicted by this tail of the curve phenomenon. And now with up to 10 years of follow-up in patients, a little bit mixing apples and oranges in terms of the dose and schedule of Ipilimumab, we now have about 22% of patients in this tail of the curve with this inflection point around 2.5 to 3 years, about approximately 22 of patients having long-term survival to single-agent Ipilimumab in patients with metastatic melanoma. But the world has changed very fast, and certainly targeting the molecule PD-1 has become very prominent. And for this cartoon to define the biology, on the left-hand side, we were looking at CTLA-4 in terms of education of the T cells and such. But even when the T cells are educated, circulate and make themselves into the tumor microenvironment, they are still kind of stiff-armed by the tumor. The activated T cells in the tumor microenvironment frequently express the exhaustion marker PD-1, and tumors make one of the natural ligands, PD-L1, and this interaction prevents the T cells from killing the tumor. Actually, the importance of this molecule in preclinical animal models has demonstrated that this interaction actually causes T cells in viral models to undergo apoptosis or programmed cell death. And while not the only checkpoint here that's involved, it's certainly a dominant one, as anti-PD-1 and anti-PD-L1 antibodies have shown a broad efficacy across multiple tumor types, both solid and liquid tumors. So again, using fully human monoclonal antibody technology, antibodies to anti-PD-1 have been developed for the treatment of melanoma. So this is just kind of the first spider plots or spaghetti plots showing nivolumab here at 3 milligrams per kilogram in previously treated patients with melanoma. And on the y-axis is the change in tumor volume from start of treatment, 0 being the start of treatment, the tumor volume at start of treatment. And on the x-axis is the time from initiation of treatment. You can see the majority of patients here have responding either responses or stabilization. And these red triangles depict new sites of disease. And by standard criteria, these patients would be deemed progressive in disease progression. But even in the presence of new lesions, many patients can have stabilization or even responsive disease over time. And again, long-term follow-up for patients here depicts that with now 5 years follow-up to nivolumab, again in typically pre-treated patients, despite the dose and schedule, that approximately now 35% or so of patients have a long-term survival, again in this inflection point that occurs sometime around 2.5 to 3 years. The next question is, well, if you have the checkpoint CTLA-4 and you have the checkpoint PD-1, what if you combine antibodies to both of those? And so this is the first combination of anti-CTLA-4 plus anti-PD-1 in melanoma, depicted here are the doses. And what we see now in the spider plots is rapid reduction in tumor burden and durability, with many patients having responses, both seen here in the spider plot and on the early CAT scan as an example of patient within the first 3 months. And subsequent to this, the phase 3 trial, whose endpoint was to compare nivo plus ipi to ipi and nivo to ipi. It was not specifically designed to compare nivo ipi to nivo, but here now with up to 5 years of follow-up, patients who received the combination had a 52% overall survival rate versus patients who had nivo alone 44% and ipi alone 26%. The combination does have higher degree of high-grade adverse events, as you may know, with about 50% of patients having high-grade adverse events in the combination. But these survival curves have continued to be followed in further detailed analysis. So the next question is, how can we improve upon these results? How can we now look past the great strides here in 2 checkpoints for a cancer and look beyond what other combinatorial approaches could be considered in the efficacy standpoint? So previously, we had done studies looking at patients receiving anti-CTLA-4 who had had previous treatment with a whole cell GM-CSF secreting vaccine. And basically what this pathology shows, I think part of it is the importance of the pathology of defining mechanisms in patients, is post-treatment biopsies had shown this necrotic deposit of melanoma with a viable rim of tumor. And that viable rim of tumor is heavily infiltrated by multiple effector immune cells, including CD4 cells, CD8 cells, CD20 cells. But what we also interestingly found is that many of the blood vessels feeding these tumor deposits had this immune-mediated vasculopathy depicted here. So this is a sick blood vessel, the lymphocytes surrounding the endothelium, necrotic debris in the center, but the vessel itself, the vessel feeding the tumor itself, is being attacked by the immune system. So this was intriguing in that the immune system could selectively attack the blood vessels specific to tumor deposits potentially. This raises one of the questions of the role of angiogenesis and immune regulation. And so we know hypoxia increases HIF-1 alpha, VEGF. VEGF itself can be a very potent regulator of dendritic cell maturation. Other cells, such as myeloid-derived suppressor cells, macrophages, make VEGF and suppress the immune system. So there's a role for potentially those molecules in suppression of the immune system. So working with our colleagues in Memorial Sloan Kettering, we looked at the potential for pretreatment VEGF levels in terms of immunity and vasculopathy depicted this. And what we found is that patients who had high VEGF levels, with whatever side, had a decrease in survival and responses compared to patients who had lower VEGF levels. So that, in addition to the pathology that I showed you, the effects of VEGF on the immune system, such as dendritic cell maturation, T cell trafficking, in this data on baseline VEGF levels, decided to look in a clinical trial of Ipilimumab, anti-CTLA-4 plus anti-VEGF bevacizumab. What we found is response rates overall of about 18%, but durable disease control about 50% of patients. At the maximum tolerated doses, complete responses of over 35%, with durable stable disease of 50% or more, and so fairly impressive compared to Ipilimumab alone. And here's a PET scan in one patient who showed before and after that the PET avidity goes down, but the anatomic lesion in the liver does not change significantly. And so it kind of shows that this patient took time before this lesion began to shrink, and that the PET scan shows the dynamic aspects of the immune responses that by standard CT criteria took a little while to appreciate. So looking at the peripheral blood before and after and comparing to a group of patients who received Ipi alone, some of the interesting characteristics that fell out is both in the CD4 and CD8 departments, there were improvements in memory responses compared to those patients who got Ipi alone as a function of treatment. And even though small in retrospective, there was some significant p-values by flow cytometry. So it raises the notion of whether blocking VEGF or targeting VEGF could have some effects on immunologic memory in circulating blood. This is an area of continued investigation. So pathologically, it was important to look at what's happening before and after. So on the left-hand side here, we have before and on treatment biopsies on Ipi plus bevacizumab, and then we have some similar biopsies on Ipi alone before and after. And we found is that patients who received bevacizumab or anti-VEGF seem to have qualitatively a larger number of CD8 infiltrating cells, even some CD163 cells, which could be either myeloid-derived suppressor cells or dendritic cells. That's further work is involved. But we also saw morphologically that the CD31 endothelium of the blood vessels changed. They became more plump, columnar, and they also seem to have biochemical activation markers such as upregulation in E-selectin. And surrounding these blood vessels was a very robust lymphocytic infiltrate, immune infiltrate that seemed to be much more so than patients got Ipi alone. So it suggested potentially whether VEGF blockade could be activating these endothelium both morphologically and biochemically to facilitate lymphocyte trafficking from the blood into the tumor microenvironment. So we also have found that there's alterations in adhesion molecules such as VCAM and ICAM on the blood vessels following bevacizumab treatment that may be further hints as to the changes in endothelium that has led to the facilitation of lymphocytes crossing the endothelium. So this work has further been developed and has been kind of confirmed that bevacizumab can increase lymphocyte infiltrates, potentially even as a single agent in preclinical models and in other clinical applications. And obviously the cancer to focus on is kidney cancer, and it really looks like the combination of anti-PD-1 Pembrolizumab plus Axitinib, which is a TKI VEGF-R123 inhibitor, seems to have a significant improvement in both progression and overall survival in patients with kidney cancer. So this notion of combining anti-angiogenesis with immune checkpoint blockade seems to be blossoming a bit, particularly in kidney cancer, and needs further investigation elsewhere. So anti-VEGF and others, CTLA-4, can be safely administered. May block important things that lead to synergistic effects, and this is probably characterized by inflammatory events, immune activation, benefits in terms of the efficacy potentially, and then this need to look at other angiogenic factors may also have important immune regulatory roles and in potential combinations for the future. So we next ask kind of the question about what drives response to checkpoint blockade, and we set up Cytop panels, and Cytop panels are using antibodies that are conjugated to heavy metals and using the mass of these heavy metals to detect the markers on immune cells as opposed to flow cytometry. In doing so, instead of having 8, 10, 12 colors with flow cytometry, we can now do scores of markers with the same samples. And this is just looking at a similar panel. What we're interested in for CyTOF is to look at the peripheral blood of patients before treatment who received anti-PD-1 alone or anti-CTLA-4 alone, to see if there's anything predictive in terms of the priming immune system or other aspects that could be predictive of outcomes. And there were certainly differences in both lymphocyte and monocyte frequencies that distinguish responders from non-responders to anti-CTLA-4 and anti-PD-1. So we specifically had found for Pembrolizumab that the number of monocytes in non-responders was lower than patients who responded, and as well in patients, lymphocytes for Pembrolizumab seemed to be a little bit higher non-responders than in responders. But importantly, when we look at specific markers in detail for patients to anti-PD-1, one of the striking features that came out is that there was decreased expression of CD69 MIP1B positive NK cells and baseline PBMCs to PD-1, suggesting that some NK activation and proliferative markers might be involved in the efficacy of anti-PD-1. We know that anti-PD-1 can be on NK cells, and so this remains another active area of investigation and may be supportive of the next study we'll talk about. So what factors of tumor microenvironment contribute to immune checkpoint blockade resistance? So there are a number of areas of investigation that's looking at that. So as a predictive biomarker, the presence or absence of CD8 infiltrate in the tumor microenvironment, particularly at the tumor stromal interface. The CD8 cells present there have been predictive of a beneficial response to anti-PD-1. The presence of interferon signatures, signaling tumor microenvironment, has also been beneficial. But things that have been associated with potential resistant mechanisms to anti-PD-1 have been mutations in the tumor themselves, particularly like JAK mutations, which would not permit interferon signaling. PD-1 expression has been a surrogate for interferon to some extent. It's a inducible ligand. And aspects of the APC machinery, specifically beta-2 mutations, which would not allow class 1 to be expressed in the tumor, and therefore CD8 cells would be challenging to lyse them and kill those cells. So those are kind of the thoughts about what the next steps of investigation would include. So we were interested in looking at whether class 1 loss could be a mechanism of resistance, and also not just class 1, but what's the role of potential class 2 expression relative to checkpoint blockade, which has been an area of investigation by a number of groups. So we took advantage of this this investigation study of a randomized study where patients with metastatic melanoma is front line, but they were randomized to either receive induction nivolumab anti-PD-1 first with a forced switch to ipilimumab anti-CTLA-4, and the other half of the patients received ipilimumab first with a forced switch to nivo. In between, everyone got blood work, but they got a biopsy before, a biopsy in between the two induction periods, a biopsy following, and then everyone received nivolumab maintenance. And in this study, we looked at by protein and IHC. Scott Rodick doing much of this work and leading this work. Class 1 expression here, and here's examples of high class 1 expression. Most nucleated normal cells will have intact class 1 expression, intermediate class 1 expression, the tumor cells here that have lost class 1 expression. Here are some patients with class 2 expression. Here, most cells will not have class 2 expression as opposed, in the medium to loss of or lack of class 2 expression. So when we looked at the patients who got IPI first versus patients who got nivo first, what we found is that patients who had a downregulation of class 1, that is a 50% reduction or loss of class 1, did not have as favorable outcomes to ipilimumab therapy first, and that they were really any benefits were dependent on class 1 expression being fairly normal. This was not true for class 2 expression. What we found, patients who got nivo first, that the class 1 was not influential whether patients had a clinical benefit or not, but that any expression of class 2, that being even 1% as scored by 2 independent pathologists, even any expression of class 2 associated with a favorable outcome to anti-PD-1 therapy. And here are some Kaplan-Meier analysis that kind of depicts this. The gray are a few patients who were not evaluable, but the patient who had IPI first, who had loss of class 1 expression, in red did fairly poorly compared to those in the blue that on the left-hand side that had class 1 intact. And as opposed to those patients who had Nivo first on the right, that there was no significant difference between them. As opposed to class 2, might be on the left-hand side first, not seem to matter, but there was a significance on the right-hand side for patients who got Nivo first, that any class 2 expression was associated with a better outcome. So we next looked at the top genes that were associated with this, and this is listing many of the genes that we found because all the patients had RNA-seq and whole exome sequencing. And what we found was that patients here, most of these associations of the top genes were associated with gamma interference signaling, which you would expect. And interestingly, some were associated with not only interference signaling, but also other potential mechanisms such as IL-15, which is involved with NK biology. So we looked at the genes for those patients who had low class 1 expression. And in patients who got Nivo first, the presence of interference signature, either published signature, the top 25 genes we looked at in our own interference signature portfolio, gene signature, that patients who had this interference signature, interference signaling, did better to Nivo first than those that did not. And interestingly, in comparison, those patients who got IPI first, those signatures did not seem to influence outcomes if they got IPI first. So we took the patients who had low class 1 expression and began to see, well, what else is going on in the tumor microenvironment? And it seems that you need interferon to still respond to anti-PD-1, interferon signature, but other gene sets that were associated with it included cells of innate immunity, here gamma delta cells on the left, on the top, and then NK cells on the bottom here. And when we looked, it seemed to be significant for those who got Nivo first, as opposed to those who got IPI first. And when able to look at pathology, Scott and his colleagues were able, Scott Rodig and his colleagues were able to find these gamma delta cells and NK cells in the tumor microenvironment. So we next looked to this trial to see if we can confirm this. And this trial was used as a registration trial for Nivo plus IPI in melanoma, and randomized patients in a 2-to-1 fashion to Nivo plus IPI versus IPI alone placebo. And so we were able to take samples from this and score them to look at and confirm the characteristics to see if both class 1 and class 2 could be involved. And what we found in the IPI alone containing arm is that downregulation or loss of class 1 had 100% negative predictive value for outcome, meaning that anyone who did fairly poorly. And while there were trends in what we saw earlier from the IPI, given it's a combination, there was nothing that was significant, but there was a confirmation of the importance of class 1 to the benefits of receiving ipilimumab. So here are the Kaplan-Meier analysis again. It's encoded for IPI on the left for class 1 expression. Patients who had lower loss of class 1 did not do as well as patients who had intact class 1. And because of this combination, that the Nivo IPI arm did not see such a significance. And again, while there was a trend towards the importance of class 2 in the Nivo containing arm, it did not reach significance. Obviously, patients getting both Nivo plus IPI. So in summary, there's an appearance that CTLA-4 blockade responses is dependent on class 1, and that PD-1 blockade is not entirely dependent on class 1. But interestingly, PD-1 blockade responses can be improved by class 2 expression, any class 2 expression, and by the presence of gamma interferon. So much of this intriguing information is asking to be looked at in other cancers and such, but also suggests that the potential that a gamma interferon signature may be from class 2 expression, CD4 help with making gamma, can activate multiple effector cells, even innate immune cells, and maybe even the roles of other cells such as gamma delta cells, as well as NK cells in the tumor microenvironment may become important even to anti-CTLA-4 blockade. And so we're working on looking at multiplex immunofluorescence of here looking at ways to look at class 1, class 2, beta 2 tumors in order to understand the role of the APC machinery, class 1, class 2, the other cells in the microenvironment that are related to efficacy for checkpoint blockade. So there's still much work that needs to be done, specifically here looking at the targets that are still being investigated, and both from a checkpoint standpoint, PD-1 is obviously up there, and even agonist targets such as CD40, OX40, 4-1BB. So there are many complexities to the tumor antigen-presenting cell or tumor T-cell interface that are currently under investigation. But also of importance is the relevance of these other cells in the tumor microenvironment. The CD8 cells are obviously critical. Other cells in the microenvironment that play a role both in effector function as well as regulatory function. Dendritic cell for antigen presentation, M1 and 2 macrophages, and then the immunity in terms of effector versus regulatory elements. T regulatory cells, tumor-associated fibroblasts, these are all play a critical role in the tumor microenvironment with relation to our ability to develop further combinatorial approaches to treat this. So there have been a number of folks that have been involved in this work in a lot of investigation trials. I want to really highlight the importance of the teamwork in this to be able to conduct these early pilot studies to kind of dissect out some of the mechanisms in people.